medical education event of the Indian Medical Association Queensland chapter. We have today as our guest speaker Dr. Sudhahar. We have our President of Indian Medical Association, Dr. Vagish Singh. Vagish's wife, Honorable Indian Consul Archana Singh. Convener of Indian Medical Association, Dr. Neeraj Khanna, GPs and specialists and eminent members. Let me take this opportunity to introduce Dr. Sudhahar Chittukatur Arthanarishwaran, very nice name, orthopedician, surgeon working at present at Greenstops Private Hospital, Mater Springfield Hospital and St. Andrews Private Hospital, Ipswich since January 2021. He has been working as a consultant for the last 11 years, orthopedician. He is from the famous state of Chennai, from Erode in Tamil Nadu. He did his MBBS 1989-1994 from Coimbatore Medical College. Master of Surgery at KEM Mumbai 1996-2000. DNB 2000, then United Kingdom 2000 to 2015. So that's a long time, 15 years. Type 1 specialist registrar training at Liverpool. Did his FRCS Edinburgh, FRCS Trauma and Ortho. Consultant in the NHS Britain 2010-2015. Then he moved into down under the lucky country, the special country, Australia, the smart country, like all of us. 2015 FRCS FA Ortho Fellow. 2015-2020, 5 years consultant and director of the orthopedic Tamworth Rural Referral Hospital. So you must have been to the Tamworth country show as well, eh? 2021 Brisbane Public Hospital Logan, special interest hip, knee, shoulder and sports medicine, work cover issues as well, health fund, rebates and self-funding private patients. His interests are in badminton, jogging and chess. That's why he looks so healthy, unlike wife, Dr. Anusha is here. Thanks for welcoming all of us. Anusha Sudhahar, obstetrician gynecologist, specialist, Ipswich Public Hospital. They have 2 kids, 18 years old son, University of Queensland, budding medicine year 1, daughter year 8, St. Aidan School. And we have our sponsors here as well. Shamai Davidson from Smith and Nephew and Raj Pratap of Bendigo Bank. Thank you. Let's move on to the talk. Thank you. Welcome, Dr. Sudhahar.
Thank you very much. Thank you, everyone. Thanks for coming. It was really nice to see everyone here. Thanks especially for IMA to support and organize this talk. I'm going to talk about the knee conditions today. Disclosure for today's event, the sponsors are Smith & Nephew and Bendigo Bank. Okay, what I'm going to talk today, I'm going to talk about 3 main topics. One is the osteoarthritis of the knee, ligament injuries, and patellar dislocation. Osteoarthritis, pretty common topic. It's always increasing all over the world due to various reasons. One of the main reasons is also increasing BMI. But there's always controversy when you have mild to moderate arthritis. Severe arthritis, we know what to do, which is often knee replacement. So I'm going to go a bit more elaborative about mild to moderate osteoarthritis. So the objective is to know how to diagnose, what are the non-operative management, how to optimize the patient preoperatively, operative management and outcomes. Diagnosis, as anything else we learn in the medical school, starts with the history, examination and an investigation including radiograph, CT and MRI. I'll go through each one. History, obviously pain is the main thing. The pain varies significantly from dull ache to sharp severe pain. In osteoarthritis, mainly it's dull ache pain or constant ache, intermittent ache. Sharp pain is not usually common. If you have a sharp pain, then probably you should think of maybe a meniscal pathology or a chondral flap. But having said that, it's still possible to get occasional sharp pain when you have a small chondral defect when it's getting under loading. The other thing along with the pain is the function. How far is the walking distance? Usually the walking distance is gradually getting reduced. It varies from people to people. Elderly people who can't walk more than half a kilometer is significant disability, but if you tend to see young people who runs marathon or does 5 to 10 kilometers every day, not able to do 2 or 3 kilometers is a pretty significant disability. And sleep. This is another significant disability for them. A lot of them complaints of sleep disturbance. They often manage to go to sleep, but they wake up halfway through, especially when they're turning or twisting. Sometimes they say they have to put a pillow under the leg, either to in between the leg or bend and put a pillow for the flexion. And if you have to wake 2 or 3 times in a day, then each night, then it's a really significant disability. The next one is stairs and sitting. In patellofemoral arthritis, sitting for a long time, followed by standing up, produce significant pain. And usually anterior knee pain. Unfortunately, mild to moderate, we don't have much answer for anterior knee pain. Stairs, in severe arthritis, it obviously affects both climbing up and down. In early arthritis, climbing down is supposed to be more problematic than climbing up. Obviously because of the eccentric contraction of the muscle and the braking force of the body. What about the mechanical symptoms? Clicking, locking, and giving way. Mechanical symptoms, usually we talk whether it's a reason for underlying meniscal pathology or a chondral flap. Arthritis as such doesn't produce much of a mechanical symptoms. But occasionally people do complain, you ask them, do you have clicking? They say yes, but it's often the crepitus rather than a real clicking, which you see when the meniscus is flipping inside the joint. Locking, the true locking is when you can have good flexion, but you can't straighten to the last 20-30 degree. But in arthritis, people often complain about pseudo-locking, which is they just feel sudden pain followed by seizing of the knee joint. They just can't do the flexion or extension. True locking, there is a mechanical problem. Something is blocking in the knee. Giving way, it's often precipitated pain, maybe quadricep inhibition because of the wasting. And what is the response to the treatment? Often the treatment could be anywhere from doing nothing, weight loss, to analgesia, but whatever it is, what is the response, how they respond. Physical examination, often you see restriction of range, swelling. Deformity is usually later, tenderness may be there. Swelling, the key thing about the swelling is how much irritation the synovium is there. The larger the effusion, you can take, there is something significantly going on inside. Usually in mild to moderate arthritis, mild effusion is present. Occasionally when there is an exacerbation, then you get a severe swelling. Investigation. The standard investigation is only X-rays. You often do AP, lateral and skyline view, which is a weight-bearing X-ray. Without weight-bearing, you can't see much about the loss of the cartilage. Do we do long leg alignment? Occasionally we do them, but mostly it's for preoperative planning, not for diagnosis as such. What about the further investigation like CT scan and MRI? CT scan is not routinely used for standard diagnosis of osteoarthritis. Only if there is a concern about the bony architecture or if the diagnosis is doubtful. Occasionally in a very young patient like less than 40 or 45, it's unlikely they develop arthritis, then you want to know anything else like a ball alignment, whether they had previous fracture or transient osteoporosis of the femoral condyle or any avascular necrosis, then maybe CT has a role. What about MRI? Certainly MRI has no real benefit in early arthritis, but certainly it can rule out other pathology, including meniscal and to know how the other compartments are doing. The other thing is von Rosenbach view, which is an X-ray where you do it in weight bearing but 30-degree flexion. Standard AP X-ray and standing straight forward may not show the full intensity of the cartilage because the functional position is 20 to 30 degrees, so the maximum cartilage loss happens in 20 to 30 degrees. For example, this is the left-hand side. You can see in standard AP X-ray, which is a weight bearing. You still see there is some gap in the medial side, which seems to be there is some cartilage still left. Leave the middle picture, but the left-hand side you can see that the cartilage is completely gone, which is 20-degree weight bearing, or 20 to 30-degree weight bearing AP X-ray. And the similar on the lateral compartment. This is an AP X-ray which shows almost normal joint line on the lateral side, but in von Rosenbach, which is 20 to 30 degree flexion AP, you see complete loss of a cartilage. This is a bone on bone. Okay, what management do we offer? Non-operative management, there's loads of them. How strong is the evidence? That's the question. Low impact exercise, there's pretty reasonable evidence to say low impact exercise, in other words, taking the gravity off as much as possible. Stationary bike, it's pretty good. The other one is any exercise in the pool, including swimming or walking in the pool, which takes the gravity off. Weight loss, unfortunately, this is the biggest thing of all. There's excellent evidence to say that even 1 kg loss on the upper body, there's a 5 times reduction in the load in the knee joint because of the joint reaction force. This has become a pretty serious thing all over the world. Now every government has come up with some kind of program to manage the high BMI. When I was in UK 10 years ago, and also in Tamworth a few years back, they've started something called similar, it's like a GLAD program. But there are so many programs where when they have mild to moderate arthritis, when they have high BMI, the government has a special program where they've been packaged to go and see under one roof, physiotherapist, dietitian, and they also have a special access to the pool, weight loss program, orthotist. So the whole aim in to reduce the demand and load on the health system. Because early to moderate osteoarthritis, there's no major treatment available, unfortunately. So there's all over the world, the BMI is increasing, the load is increasing. And I will talk about a little bit more about the braces and the medication and injection. What are the medication injection available? Obviously, painkiller is the main thing. Once you go beyond the paracetamol, then you have the non-steroidal anti-inflammatory, COX-2 inhibitors, and about steroid injection, which is very commonly used. Any nutrition supplements and vitamins. Often the common one used is chondroitin sulfate and glucosamine. And any topical, the main thing used is any anti-inflammatory gel. Acupuncture, still a lot of them tries initially. PRP, stem cells, and viscosupplementation injection. This was a big database from USA. There's a 2004 till 2009. Nearly 11 million patients' data was being recorded, out of which nearly 13,000 patients had total knee in 2009 with osteoarthritis. The whole database is to see what kind of non-operative management they had 5 years before they had the surgery. That's from 2004 till 2009. If you go through it, only 10% had a physical therapy specific to osteoarthritis. And if you really see, the braces has hardly much role in it, it's only 2.6% had it. And acupuncture, well, nowadays they try all kind of modality for early to moderate arthritis, 0.52%. But interesting, steroid, 50% of them had steroid injection. Is it beneficial? It's hard to know, but it's one of the cheap and least invasive. It is invasive, but that's the least complicated invasive option available. Viscosupplementation is only 15%. Obviously, again, it's not that cost effective and it's not still proven to be very useful. And what about arthroscopy? Well, nearly 10 years ago, every orthopedic list will have 2 or 3 knee arthroscopy, which is often mild to moderate osteoarthritis. We'll be debriding them, nothing else. We'll be washing it out, debriding it out. In 2010, when I was in UK, the evidence started to disappear, so the health from UK has pulled out the funding for the debridement. And since 2015 in Australia, almost the health fund has stopped funding for any debridement for osteoarthritis, which shows there's no evidence. There was 20% of these patients had arthroscopy, and out of which 35% didn't have anything other than just debridement. There was no code recorded saying there was any meniscal pathology. And interestingly, of these 2,000 patients, of these 2,500, nearly 2,000 of them had totally within a year. So it's really worth doing a knee arthroscopy just for a year. We don't know how they were for that 1 year period, whether it's helpful for 6 weeks, 3 months, we don't know. Okay, what about all this medication? I mean, some people comes and they said, no, I'm not interested in taking painkillers or anti-inflammatory. They may be happy to take painkillers, but not really anti-inflammatory. Well, they also have risk with it. They also have adverse effect. Up to nearly 20% of ulceration can happen in elderly. COX-2 inhibitors, even then, they produce 7 to 8% ulceration. And let's talk about the steroid. Steroid injection, as we saw from the database, obviously 50% of those databases had steroid injection. It's very easy, simple, very effective. Often we were giving the steroid injection in the clinics. Now we started giving it in the radiology department and ultrasound or CT guided. How many injections you can do? What exactly does it do? We don't know what exactly it does. Probably it reduces the inflammation in the synovium. And how many injections? Maybe 2, maybe 3. Does it do any long-term effect? No, it doesn't really produce any long-term consequence. Occasionally, the steroid can precipitate and can produce a pseudo-precipitate, like a pseudo-septic type of reaction. If either the patient is too young, very early arthritis, then the real indication for steroid injection when they have acute flare-up. They've been managing it, a little bit of flaring now and then, they're managing with whatever they can. Suddenly acutely flared up, which is obviously evident by significant swelling, inflammation of the synovium, then the steroid injection has a role on it. Because you can aspirate the fluid and put the steroid, and probably takes the acute flare up, and they should go back to their normal managing. Maybe 2 to 3 per year, or unless they are so elderly, they are unfit, then you can keep them going with quite a few more injections. The only risk is, if you're considering any intervention like joint arthroplasty, then there is a chance for infection. If you do it within 3 to 6 months, few years back, we tried to avoid doing arthroplasty within a year of having injection. It went to 6 months, there's no real evidence, but maybe 3 to 6 months, you try to avoid having a steroid injection before the arthroplasty. What about viscosupplementation tablets? It's not a prescription. So it's just only 2 things available to my knowledge is chondroitin sulfate and glucosamine. So far there's no real evidence to say they work. But again, in early and moderate arthritis, we tell them to take it. And they have to try it for 3 months minimum. If it doesn't work, then they can discard it. There are a few people who it helps as well. The only thing is to look for allergies to shellfish, because they can be allergic to them if they are allergic to shellfish. Bracing looks quite interesting if you really look into the concept of it, because it offloads the joint where there is an arthritis. Like if you see in this middle picture, there's arthritis in the middle compartment. You put the brace, which pulls the knee, like there is a pivot point at the lateral side or the outer side where the arthritis is in the medial side, and you strap the leg towards it. Yeah, it offloads it if you can, but the problem is it has to work on the skin. There has to be 3 points of pressure in the skin, so it's not going to be possible. Maybe for a day or 2, that's it. It's not going to be possible to put pressure on the knee. And also, once you put the load, like walking or running or even standard walking or twisting, you don't know how much function the knee brace is going to help. So there is loads of braces available, loads of marketing from the extremes of the prices, but there's no real evidence whether it's working or not. We do have braces for patellofemoral support as well, which tries to offload it. Occasionally patients feel really helpful. Maybe it is helpful intermittently, like climbing stairs sometimes. But again, there's no real evidence to it. Topical treatment? Probably 2 or 3 days initially, maybe. More than me, all the GPs will have more knowledge about how evidence it is. And then a lot of them, when they come to me first time, they'll ask me if they haven't used it. If they've used it, they won't ask me for it at all. It's supposed to release substance P and affect the histamine. I mentioned this acupuncture for quite some time because a lot of patients tries, at least if you ask them, they would have tried something like this. And apparently there's so many RCT for acupuncture. Some of them say it lasts for 2 to 3 weeks, and it's mainly pain relief. I don't have anything else to say about that. PRP injection. This is another thing which has been in the orthopedics for the last 5 to 10 years, which seems to be coming up in every avenue of it. Whether we have a tendinitis, arthritis, or whether we do a ACL reconstruction or anything, they try to put some amount of PRP into it. What is the evidence there? There were level 1 studies with 78 patients shows maybe slight improvement in early arthritis up to 6 months. But there were so many level 1 studies showing there's no better than hyaluronic acid or viscosupplementation injection. Also, they say there's higher adverse effect with PRP. And for PRP, you need a special machine, and you have to prepare it as well. There are so many papers saying it's hardly any beneficial than hyaluronic acid, not as any more beneficial than placebo. There's one Australian current concept review, there's one evidence of all the soft tissue and arthritis for tennis elbow, they've shown there is some evidence with PRP injection. And in UK study, for tendoachilles tendinitis, there's some evidence. Again, they are not the primary indication. They are often once they fail with all the other management, including steroid injection, physio, stretching, only for resistant or recurrent tendinitis of tendoachilles or tennis elbow, then you can consider PRP. Why is there a variation? Some papers saying some of them are useful, some of them not useful. One of them have presented this may be the reason, which is like all PRP are not same, different condition has to be different. Again, it doesn't seem to be really there is any evidence for it. But they say in osteoarthritis you should have a leukocyte poor PRP. For tendinopathy it has to be leukocyte rich PRP. And for muscle repair, platelet poor PRP. Again, I don't know how they prepare it. And I don't know when there is a platelet rich PRP, how a platelet can be depleted in it. Viscosupplementation. For the last 10 years, it's been coming and going. Various preparation is coming. Single injection, 2 injections, 3 injections. It started nearly 10, 15 years ago. The key thing is everything contains hyaluronic acid. It is the single most important molecule in the joint, which lowers the friction and provides lubrication to the joint. It's prepared either from bacterial fermentation or chicken coop. The lowest friction coefficient of friction in any joint, including the artificial joints, is because of hyaluronic acid in the synovial joint. There are 3 factors to it makes the efficiency. One is its molecular weight, cross-linking, and protein concentration. Generally, in young, healthy synovial fluid, you see a molecular weight and elasticity is quite high. In osteoarthritis, it's really low both. And the synovial, all the injections, they have varying proportions. Some are high, some are not that high. How does it work? It goes in, it stays there, then it tries to trigger to produce hyaluronic acid endogenously, because no matter what you put, it's not as good as what can be prepared by the body. So how long it stays? So that depends upon the cross-linking. The longer the cross-linking, the half-life is longer. So anything that has high cross-linking, you'll have to stay there for 6 months roughly. If there is not much cross-linking, it only stays for 10 days or roughly something like that. And, well, sorry, if there's no cross-link, it only stays for 1 day. And what else does it do? It not only increases the endogenous hyaluron, it also inhibits the matrix metalloproteinase, which is one of the key lysosomal enzyme which degrades all the collagen and cartilage. And what about the protein concentration? A lot of these hyaluronic acid injections have varying amount of protein concentration. It doesn't happen often, but the protein can precipitate, then it can produce pseudoseptic reaction. Acute intense inflammatory condition that almost look like a septic arthritis once you had the injection. So there's so many variations, so many on the market. It started with 10 years ago, we had 3 injections with one company, the other one had 1 injection, but so many studies says there wasn't any real evidence. And that's, of course, it's much more expensive than steroid injection. There was some studies saying that probably some benefit when you do inject it after the arthroscopy. So there are certain surgeons who try to put it after arthroscopy. Again, it's not a universal work. And most of the studies shows they know better than steroid. What is the reasons? Recent one is they've combined both steroid and viscosupplementation. Syngal is one of the company which, what the name of the drug which has been used. It's been there in the Australian market for more than a year. I've never used it. And you can try it, but you don't know what helps, whether it's the steroid or the viscosupplementation. If it's just the steroid, then it's only, you're spending so much money for adding the viscosupplementation to it. And obviously the steroid they use, you can use dipamidrone or triamcinolone. They use triamcinolone, and it seems to be lasting longer. In conclusion, viscosupplementation, again, mild to moderate. You can try it, but we don't know whether it's going to help or not. Maybe Syngal is more helpful. Again, I don't know the cost benefit. That's non-operative management. Let's go to the surgical interventions. You have arthroscopy, osteotomy, uni knee or a partial knee replacement, and total knee replacement. As I touched before, arthroscopy, the number of procedure for osteoarthritis is very, very little. Maybe a degenerative meniscal tear, which is producing mechanical symptoms, that's role into it. The AOA, which is Australian Orthopedic Association, has provided a meniscal guide, which is available online. And they say not to narrow the indication for arthroscopy in mild to moderate or any arthritic condition. And again, there is no role for urgent surgery in degenerative meniscal tear. And of course, we don't repair meniscus in degenerative tear at all. Osteotomy. 35 years ago, when the joint wasn't that great, osteotomy used to be slightly more popular. But since the arthroplasty joint replacement is not, since the arthroplasty, osteotomy is not that popular. But in the last 10 years, slowly it started coming back. Why it started to coming back? Because you start seeing more and more younger people wanting to have knee replacement. So osteotomy is really good for young, physiologically active, not just young, they have to be like a heavy manual laborer, builder who climbs up and down the ladder, where the joint is not the best thing. You have all the evidence if you do a total knee replacement or half knee replacement, less than 55 years, the revision is higher. And malalignment, yes, you can consider osteotomy. And the key thing is, it has to be single compartment. The other compartments should be intact. Occasionally, we can use osteotomy along with contour restoration. Like if you have arthritis in one compartment, a small focal cartilage loss, then you can restore it by cartilage transplant, either MACI or ACI, where you take the cartilage, culture it, grow it and put it back, and then you do an osteotomy just to offload it. Again, it's not indicated in arthritis as such, it's only for focal contour loss. Again, there's no evidence. A lot of the arthroscopy and all the biopsy that was done after these procedures, they still only go fiber cartilage. They don't go the hyaline cartilage. Ligament stabilization, which is not really part of this early. So what exactly is the osteotomy does? When you see in this x-ray, normally when you stand, the weight-bearing axis from the center of the hip goes through the center of the knee to the center of the ankle. And the center of the knee can go anywhere from the center to up to 10 millimeter medially. In arthritis, as the medial side bears away or the lateral side bears away, the mechanical axis shift. In other words, you start putting more weight or more load in already those joint or part of the joint which is already arthritis, which is painful. When you have medial compartment arthritis, then you have a varus, which means the mechanical axis shifted medially, which means you'll be putting more load on the medial side. So how does osteotomy work? You try to cut the bone and shift the leg a little bit laterally and restore the joint mechanical axis again. In other words, you push this weight-bearing axis from nearly by 62% something, which means you're shifting the load from the arthritic to non-arthritic joint. But that's not natural. So you're going to put more load on the joint, which is not naturally taking more load. So which means at some point it's going to fail. So that's the disadvantage of it. For the younger patient, this is the best option because they have still got their own knee and they can do the full movement and everything. There's no restriction with them. And you don't shift it that much if you're just doing ligament surgery, you only shift it up to 50%. That's just to offload for the ligaments to heal. This is an example of how an osteotomy, there's a medial compartment arthritis, there is a cut done, you just push it. If you put a long axis, the joint load from in here, you'll shift it up to this part, approximately around this spine. And if you have a valgus arthritis, then you don't do it in the tibia, you tend to do it in the femur. Again, you cut the bone, either you take the like a closing wedge or open wedge osteotomy, which means you take the bone away or put a bone in to correct deformity. In femur, you often take the bone away. Why we do it in femur for lateral compartment arthritis? Because often the deformity is in the femur. Concern, how long it lasts? Will it help the patient? Instead of doing it, can we just do a half knee replacement? Will it have any effect on the future knee replacement? And there is a pretty good result for up to 10 years if you do a good high tibial osteotomy. As I said before, they can go back without any restriction, doing all their activities, squatting, kneeling, climbing ladder, everything. There are a group of people it definitely helps. Is uni better? Uni is slightly better in low demand patient, but not in high demand. And both, either uni or total knee, both will affect the future knee replacement. There are several systematic reviews which look into uni versus high tibial osteotomy. Some of them says uni replacement has uni or partial knee replacement has less revision and less complication pain. But unfortunately, high tibial osteotomy is going to fail at some point because the other compartment has to fail. So you don't know whether the complication, what it says is really failure of the other compartment or that's the real complication. Functional score is almost similar, and good to excellent result are almost similar. As I said before, it's mainly for younger and more active patient. Converting both of them is demanding, because both of them you can't do a straightforward simple knee replacement because you've shifted the axis, you have to do a complex knee replacement which often involves stem and wedges. Previously they say either doing a half knee to total or high tibial to total, the success is as good as only revision knee replacement. But now they're saying it's probably as good as total knee replacement. Partial knee replacement. The commonest one we do is for the medial side. 80% of them is for the medial side. Occasionally for the patellofemoral, and again not for a patient. Lateral, 20% because the lateral side is slightly more lax and they don't last long. Total knee, in the last 30, 40 years, nothing much has changed. Maybe a little bit difference in metallurgy, a little bit difference in the poly we use, but otherwise most of them remain the same. Slowly, slightly increasing with uncemented, but nothing major change. Even though we say total knee, we don't that much replace the patella. Maybe 50% of the surgeon replace, 50% don't replace the patella. Either way, you have only 1 to 2% of complication. So either way, 1 to 2% will come back with the pain. Okay, that concludes the osteoarthritis. Let's go a bit about the sports disorder. Ligament injury. I'll touch base with the ACL and patellar dislocation and a little bit about the knee dislocation. I won't talk too much about the meniscal injury. ACL, it's been always a hot topic because more and more people are participating in sports, and especially more and more younger people, teenager. So the incidents are always creeping up. What are the surgical decisions? So many options. What graft to use, when to operate, whether to operate or not. Where do they present? They don't present all the time to the emergency or to the fracture clinic. They may present to the physios, they may present to the GPs, or sometimes they come only after a few months as a late presentation. The key question is, can we put the person back to pre-injury level? The pre-injury level, in most cases, has to be, can they go back and do the high-intensity sports activities, not normal activities. Very few people can't do their normal day-to-day walking and day-to-day activities. More common happening in sports in women now, obviously more teenagers are participating in sports, and there are also anatomical and physiological reason. Women, the femoral notch is supposed to be small and the ligament is supposed to be small. Also a physiological reason, because they're supposed to be landing pattern is different. They're supposed to be having a hyperextension valgus, and apparently there's some discrimination in the proprioception as well. This is a very, very old paper. In general, 1/3 of the ACL injury probably doesn't need surgery. 1/3 will need immediate surgery, 1/3 will need delayed surgery. Not everyone will agree with it because more and more newer ones, if you're really young, they want to fix it because they don't want to leave it. This is one of the features showing what the landing pattern is, how the next one will be much better. The left-hand side shows how much the pelvis is tilted. When you land up, the whole body shifted as well. The right side shows, even though the valgus is not hugely different, see the pelvis is squared and the upper body is squared. So this is one of the examples of abnormal landing pattern which precipitate the ACL, especially in teenage women. Again, I want to touch base about the ACL with open physis because more and more teenagers are participating in so intense sports activities. Anywhere between 10 to 14, there are a lot of ACL injuries. And less than 10 is not that common. It's very difficult to treat because the physis is still open. It will be hard to reconstruct them. About 12, most of the time we can treat it like an adult, but you just have to look into the physis, how much is closed or not. 10 to 12, we can see how it is, and we can pass the graft, but probably we'll have to do a small graft, only single pass, and don't cross with any metal work across the physis. These are the few photographs showing that is the physis line, here's the physis line, and the ECL, you just try to do it through the epiphysis and fix it in the epiphysis. It technically is going to be difficult because it will be very, very shallow tunnel, which is hard to make it. Sometimes you can go through the physis, but fix it very high, and fix it very high. Again, as I said, that will be for 10 to 12 years, and you have to keep the tunnel size really small, because the bigger the size, then you're going to damage the physis to a level that growth arresting deformity is going to happen. And sometimes you may have to do what is called as a physis sparing, which means you don't cross through the bone at all. You pull it through the joint at the top of it and pull it out and fix it with the top of the metaphysis, which is again slightly different to the standard procedure, but that's also what's for the open physis. Graft choices. Majority of the time we take hamstring. We take either gracilis in SMET or SMET on its own. You either double it, triple it, we can do anything. But most of the time in Australia is autograft. Bone patella bone, we used to take it 10, 15 years ago. Even now, some people do it for high intensity professional players, but they get a lot of anterior knee pain and patellofemoral arthritis. In America, routinely they use allograft because they don't want to touch their athletes or the sports person's hamstring. Functionally, they can have slight difficulty in running backwards or doing hurdles jump, but otherwise they don't have huge difference. When do I use allograft? Either revision setting or in a multi-ligament conditions. As I said, mentioned about PRP, everything they were in the last 5 to 10 years, they were trying to put some PRP, like for the ACL, they used to dip the graft in the PRP and fix it, but there is no real role for it anymore. Latest evidence, because of so many ACLs are done, they found there is five times more infection rate in professional athletes, even though the total percentage is much less. And also the other group is above 40. We started doing more and more ACL, which wasn't that common before, because more and more people want to continue doing sports. I've done the oldest I've done is 55. Obviously above 50, you don't know how well the graft is going to integrate into the bone. But there are people who come with pretty good cartilage, no evidence of any arthritis, and very, very high active. And even at 55, 50, up to 57, I haven't done anything more than that. Graft diameter, you try to put bigger to make it stronger, but really bigger can make arthrofibrosis as well. Multi-ligament injury, it used to be high velocity injury, really like a road traffic accident. But unfortunately now it's happening with a lot of contact spirals, including soccer and rugby. 10 years ago, most of them tend to be reduced if needed external fixated or put in a plaster. Wait for 6 weeks to 3 months, and see which ligament is gone, and then reconstruct. But the last nearly 5-10 years, we've started reconstructing more and more, and the outcome is much better. This is what the presentation, which we don't see that common. Either they are reduced at the time of the incident, or they come to the ED. But this kind of presentation can be there even with the trampoline jump. Yeah, I've seen 2 or 3 trampoline jumpers, and also there is a gymnast, what the name of her, an American, who had completely dislocated both her knee in one jump. You often, as I said, is high velocity, but you can have neurovascular injury. There's high incidence of damaging the common cranial nerve and popliteal artery. ACL, on its own, we try to delay the surgery at least for 2 to 3 weeks, just to avoid the stiffness. Before that, you want a good range. But multi-ligament, you want to do it within 10 days to 2 weeks to avoid it becoming all scarred up. And what graft? Probably allograft is the best, because you have to reconstruct so many ligaments. You get the allograft rather than sacrificing all the ligaments, all the tendons in already dislocated knee. The surgery can have 3 to 4 hours. You may have to do it at 2 separate settings. Sometimes it can be difficult surgery, especially doing posterior cruciate, and you need a very intense rehab. For 6 weeks, only passive range, they can't do active range. So there will be some form of brace for minimum 3 to 6 months. And they'll have to be protected, and passive range will only lying in prone position as well. Just an example of an X-ray shows how it looks when you're reconstructing 4 or 5 ligaments in the knee. And this is the key thing that when we do in the PCL, that's very close to the back, whereas exactly popliteal vessel will be very close. So you have to use all the protection, image intensifier, arthroscopy to make sure you're not damaging it, but that's really risky surgery. The last is the patellar dislocation. Again, the numbers are going up and up now. And the same recent female teenager valgus hyperextension. The good thing is the recurrence is only 20%. So 80% of them doesn't need any surgery. Single episode of dislocation, non-operative management, they are fine. The many underlying causes, like is there a femoral anteversion? Do they have genu valga? Is there any trochlear dysplasia? Is there any excess tibial torsion? So many anatomical reasons. 5-10 years ago, we used to treat each anatomical reason according to what exactly underlying pathology is. But now, we just reconstruct the medial patellofemoral ligament, which is a game changer. No matter what the underlying cause, if they have dislocation, if needs recurrent dislocation, if needs surgery, we just do a medial patellofemoral reconstruction. This is what I mentioned before. And this is what the reconstruction is. This is the ligament. If it ruptures, we just take hamstring and semi-T, fix it to the patella, we loop it. The actual ligament is only 2 to 3 millimeter. The one you reconstruct, each limb will be 3 to 4 millimeters, so almost 3-4 times the strength of it. So irrespective of the underlying pathology, this is the primary treatment we are doing for the last 5-10 years or so. And if it fails, then we can think about whether we need to do anything bigger. Sometimes we may have to combine with the other procedure like tibial-to-tibial osteotomy or correcting the trochlea, maybe doing a lateral release if it's really chronic or if it's really tight. That's it. Thank you, everyone.